Today our case it's hip pain. Okay, you will see this a lot in the clinic. Anything related to joints, knee, hip, etc. Uh, it will be a pediatric case. Uh, Usually we see hip pain and arthritis in general in older population around 70, 50 years old. But also in pediatric cases, you will see those cases. Our first presentation, this is a 7 years old female presented to the office with acute right hip pain and a significant limitation to the physical activity of the right hip. The patient marks the pain 6 out of 10. The symptoms have been present for 2 days. Past medical history is clean except for otitis media treated around age 2 years old. Family history shows ankle with the sickle cell anemia, otherwise clear. Vitals are normal limits. BBB is good. Temp is high and heart rate a little bit high. Respiratory rate is okay and saturation is normal. As we usually do with the cases, we go and we see the first presentation and then we order a kind of a physical examination. What do you think we should order here for this case?
X-ray.
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 But before we go with the
Physical
physical examination,
examination, hip examination.
hip examination, yeah. What else?
Vitamin D.
We will think about those, but like as the first presentation, as the patient comes to us, it's either one of both. Either we do physical examination or we manage the patient in the emergency. For example, if you have a pain, we start a pain medication.
So I don't think the pain is that high.
6 out of 10 is high.
It's high.
It's high. It's moderate to severe. NSAIDs, okay. We will do NSAIDs. What else? So let's talk about the physical examination. You said hip examination. That's
Temperature is high,
okay.
so definitely look into that.
What?
High temperature could be an infection.
Okay. So,
Antibiotics.
hmm but still, I'm talking about physical examination. Hip and general, we will see the whole body. So we
What
see,
they look like. They're
yeah,
kind
how they look like. If they have jaundice, if they have anemia, etc., paleness. Okay, then chest examination, super important because maybe it's an infection, as like
Ah.
chest, like a cardiovascular and lungs. Maybe the patient have pneumonia, maybe they have everything. So we do chest examination. Also, we do abdominal. Why? Because the patient have a history of sickle cell anemia. So it could be an acute, yes. Also, it could be like an acute chest pain, like you don't know, maybe it's like a sickle cell crisis. So we should check this also. Okay. The physical examination was like this. General, patient was feverish. Okay. No paleness, no edema, no jaundice. Okay. The chest was a clear. So the chest and lung was a clear auscultation. There is no wheezing and there is no ronking. So this is a clear for a pneumonia or like acute chest pain, as for acute chest syndrome for sickle cell. Cardiovascular, we have systolic murmur, grade 2 out of 6, heard in the left sternal border. Otherwise, unremarkable. Do you think this systolic murmur is normal or not? 2 out of 6 in left sternal border.
She's 7 years old, right?
Yes.
Systolic murmurs are usually not normal.
No, not normal.
I think they are normal.
It is normal.
Normal.
If it's a child,
Because maybe there is a congenital abnormality that's gonna close on its own.
no. This is if it's a holosystolic murmur. Diastolic, never normal. If you see diastolic murmur, diastolic murmur, it's never normal. Okay, so this is totally normal. Plus, we have an infection here, so it could be because of the overload over the heart. So it's totally normal. Okay, think about it like this. Abdominal is totally normal. Also, are remarkable. Musculoskeletal and extremity, we have a redness and swelling of the right hip, increased the local skin temperature and tenderness, restricted limb movement due to the pain. What do you think about this?
Inflammation.
Yes, there's inflammation, but
Arthritis, but we don't know if it's
Juvenile,
if it's reactive or
okay, that's actually good. Yeah, what, you said something?
juvenile idiopathic arthritis.
It could be. So, coming back to this physical examination and the first presentation, what do you think it looks like more? You said juvenile idiopathic arthritis. Yeah, this is one of your differentials. But
we
Do-
look into osteomyelitis. Maybe.
Could be. Yep.
Maybe reactive. It can be.
Yes, reactive arthritis. You mean.
Yes,
It could be. Yes, it could
because
be.
of the high temperature. Might
Yep.
be an infection. The infection caused the
hmm
arthritis.
But first of all, we said we should manage this pain. Okay, so it's 6 out of 10, and the patient is also feverish. So at least we should manage the pain and the fever, and especially in exams, like for example, step three CCS, which like once they give you a cases, etc. If you don't manage the pain and the fever first, even like before doing your differentials, you lose a point. So whenever you find a patient have a fever or a pain, you start with with the paracetamol, which is your Tylenol, and my NSAIDs. Why NSAIDs? Since the pain is like 6 out of 10, you won't go with morphine. Okay, it's so much stronger. You go with something moderate, like ibuprofen and ketorolac. So don't forget this. Super important. IV saline not always here required because it's just a joint pain. If it's like pneumonia or something which is more complicated, I will recommend doing IV saline. So our differentials, we said it could be juvenile idiopathic arthritis, could be osteomyelitis. What else? The patient is 7 years old who who presented only
Vascular occlusion.
avascular necrosis. You mean?
Yeah,
Yeah, it could be
vascular occlusion.
since we have sickle cell anemia history. Yeah,
Yeah, from
yeah,
vascular occlusion of the blood cells from sickle cell anemia.
it's possible, but there is more higher in the differential. Fever with joint pain. A young female could be septic arthritis.
Septic arthritis.
Yes, because maybe it's an infection leads to arthritis. You want to say something?
Yeah, why couldn't it be normal? I think all children have this pain, unless they are in the temperature.
Why couldn't it be normal? That's a good. But the important thing here, we have a fever, fever never be normal. So if it's, for example, if it's only pain and it started 2 days without fever, it's not normal. But there's other condition which is especially like after a viral infection is called a transient synovitis. Okay, it's a viral infection affecting the hip, will lead to a little bit of pain for a couple of days and then it will disappear. Okay, but in this case, you have a fever, you have an unstable patient. It's never normal. You need to check.
We manage the fever to know if the fever is correlated with the arthritis or not.
Why you manage the fever first? You mean, for example, right?
I mean, there are two questions. Why do we manage the fever, and also how do you know if they're connected or not?
You manage the fever first because you want to comfortable the patient. They are in fever, and you don't want to make them wait until you do your differentials and wait your labs. Your labs will take sometimes days, sometimes hour, and the patient are uncomfortable. So you need to measure it. Plus, if you believe or not, there's a lot of studies shows that if you manage the fever early, you are decreasing the mortality of the patient by like I think 20% to 30%. So that's a huge number. Plus,
Can it be rheumatic fever?
it could be, but you said juvenile idiopathic, so it's count as a rheumatic fever. Rheumatic, you mean
Acute?
acute rheumatic fever?
Yeah,
Acute rheumatic fever. First of all, you will have
And there will
a
be physical presentations to indicate acute.
there is, but the most important, the joint pain will be like a migratory. So it starts at the hand, then in the legs, and left leg. So it'd be for a long time, more than 2 days. Plus, there's like a heart issues. There's also the skin, which is you see a nodular in the fingers. The heart examination was normal, so that's ruled out acute rheumatic fever. And usually they have like a sore throat, also picture of streptococcus infection. So the differentials was as the
I'm sorry for interrupting. Yeah, I saw it. I saw it now because
okay.
I'm coming late, so I'm asking for the differential diagnosis that you put.
Okay, right
So
now we're
explain.
seeing it. What? So the differential diagnosis, we have septic arthritis, the highest one. Since we had a fever, we had also a presentation which just looked like septic arthritis. Juvenile arthritis, why it's the second one? Because as I said, this is usually it's for a long time. You see it as like months or sometimes even a years, and the typical picture that fever comes and goes. So fever start At the second day, then let's say disappear for 1 week and then comes again. Okay, so it's more like a chronic picture with a fever disappear and comes. That's a juvenile arthritis, but we need to put it in our differentials. Avascular necrosis because we have a patient who have a history of sickle cell disease, so we need to put this on. Also osteomyelitis, super important. Arthritis, not common in children. Why? Because it's mostly seen with the sexual diseases, for example, like chlamydia and gonorrhea, and you're not expected a patient who is 7 years old to be actively sex. And we have a Lyme arthritis, super important. Always put Lyme in your differential because it may be Lyme, and you cannot detect it until you do only one test, which is the serology for Lyme. So always keep this in your mind. But to have a have a specific signs, which is the erythema migrans and yeah. Yep. And the heart issues. But sometime at the first days, it will not present any of those symptoms, only the joint pain. So keep this in your mind. And the last one is cellulitis. Cellulitis, I think it's the lowest one because we have a joint pain. And cellulitis, that's only in the skin, but you should put it also in your differentials. So what do you think about the workup?
I have a question, please.
Yes. Yes.
Could this patient have also sickle cell anemia, or that's tricky, information that
I
they
get
put?
Actually, in our differential, we have the third one, which is avascular necrosis. Avascular necrosis can be caused by sickle cell anemia. That's why we put it in our differential. Why I didn't put like as a sickle cell itself? Because we didn't have the full picture, which is the abdominal pain, the respiratory pain, etc., the respiratory insufficiency. We only had the joint pain. So if it's only joint pain and you have a sickle cell, you put avascular necrosis. Okay, and then if it's like it's positive for the sickle cell, you would do your workup according to sickle cell disease.
Thank you so much.
Okay. So what do you think about the workup? What should we order? Going back to our
CBC, CRP, ESR.
CBC,
okay, CBC, CRB. You said blood culture.
yeah, blood culture.
Yes, important. What else?
ESR,
What?
ESR, CRP.
Okay. But as you see, the whole list is about arthritis, MRI, but there's something more important.
Do you mean culture of synovial for the synovial joint or
Synovial
something?
fluid. Synovial fluid. Okay. First of all, you need to do
Aspiration.
there's another name for it. You don't know it.
Is it?
Like how you take the synovial fluid from the joint. There's a name for this process.
Synthesis.
Aspiration, right?
Arthrosynthesis.
Arthrosynthesis.
Yes, right.
Arthrosynthesis. This is actually the only thing that will diagnose you. Okay, X-ray may guide you, MRI, but you cannot diagnose those without this. Okay. So synovial fluid arthrosynthesis, you take a needle and then you aspirate the synovial fluid, and you will see the cytology of it, the bacteria, which is for example, if it's septic arthritis, if it's like juvenile, you will check it. Even sometimes, like if you have a gout or you have a reactive arthritis, you cannot diagnose those without this test. Okay, we said synovial fluid, which is arthrocentesis, also CBC, CRP, and CMP. What also? X-ray and MRI. Is there something else?
I have a question. We excluded rheumatoid arthritis because first it's a child and also the disease is not progressive, right? Rheumatoid arthritis is progressive. It goes joint by joint, so we don't need to do genetic study, or like we don't need to scan for specific chromosomes.
When we say that we exclude, we means that we put it down in the differential, but we didn't exclude it 100% until we get our labs. So maybe that's a typical picture of rheumatoid arthritis. That's why we need something to confirm it, which is rheumatoid factor, ANA, and ESR. And DNA. If those,
Maybe HIV,
you don't do this until you get your first diagnosis test. For example, let's say rheumatoid factor is positive and ESR is positive. In this case, then you go with the genetic test. You don't jump directly to the genetic test because you don't want to bias it. Okay, and also they took a lot of time, like around 2 days or 3 days. So you need something faster, right?
Well, what about peripheral blood smear? If we are suspect for
Sorry.
sickle cell anemia, is it accurate in this case or?
Yeah. It's also we need it, but usually, like when you order CBC, it's already with it.
Blood
So
smear?
yes, the preferred
Hmm.
blood smear. Usually, you order CBC with it.
Mm-hmm.
Sometimes you put it in the note, but I think in the exams it's all. I mean, it's with it already. You will find it.
Mm-hmm.
Okay. Okay. Also about Lyme disease, we will order a Lyme serology. Super
Lyme
important.
serology.
Yeah, Lyme serology. This is the only thing that you can diagnose Lyme. You cannot do anything else. Only Lyme serology. Okay, so this is our workup here: CBC, CMB, ESR, and CRP. Um,
Yeah, I have a question. I'm sorry. You asked about the Lyme disease.
mhm.
Is erythema
Like,
multiform, right?
like,
Migrants. Yes,
mhm.
erythema migrans is absolutely 100% specific for Lyme. Is it? We don't need to further investigation if we see this kind of feature in the patient, or we
I
should
got you.
also go for Lyme serology.
No, you need
Any?
to go with it. Also, like if you have, even like if you have erythema migrans, you need like to confirm the diagnosis. You got me.
Yeah. Okay.
Haptoglobin, why? We said okay, see, like CBC, CMB, and ESR, CRP. What about haptoglobin? Why? Why order this?
Hemolytic anemia.
Yes, in hemolytic anemia,
Hemolysis should be low.
yeah,
Hemolysis
yes,
low.
yes, it would be low. So this is super important. Always, if you suspect something like sickle cell, GCBD deficiency, or like I don't know, like sickle cell, as we said, or like sideroblast, anything related to hemolytic anemia, always keep haptoglobin in your workup. Rheumatoid factor and ANA to
And AA.
yes, also to amisma to rule out or end
Hemolytic.
the rheumatic arthritis, Lyme, serology, and hep X-ray. Also ultrasound.
Mm-hmm.
Ultrasound is super important. It's
The blood flow. Check blood flow.
not for the hep
Yeah, yeah, yeah.
to check if there's, for example, an infusion to
Uh-huh.
diagnose
Mhm.
rheumatic arthritis. So you see an infusion in the ultrasound. And it's super fast. Just you grab it by the bed next to the bed, then you diagnose it. Blood culture, super important. Don't start antibiotic until you get your blood culture. You will take blood culture and you give empiric antibiotic if it's septic arthritis. We don't know still. And the synovial analysis. This is the most important part. Usually in the exams, in the synovial analysis, you will order each the culture. You will take it alone. The cytology is alone. Let's say the WBC, everything is alone. Okay, in the exam. So always take care of this. The same thing goes, I think, for lumbar puncture. If you order lumbar puncture, they will only do the procedure, but they won't include the CBC, the like this, like for example, the serology of it. You need to order each one alone in the exam.
Ah, yeah.
You got it. So this is important.
So synovial arthrocentesis and then full analysis for the synovial.
Yes. Okay, the workup was like this. CBC was high, 24,000. The CMP is normal. ESR is high. CRP is high. Haptoglobin is normal. Rheumatoid factor is normal. Lyme is normal. Hep X-ray show and clear or fuzzy joint capsule with a widened joint space. Ultrasound shows significant joint diffusion, fluid and thickening of the joint capsule. Blood culture was negative. And synovial analysis. Look, the last one, positive for
Yeah,
Streptococcus
Streptococcus
pyogenes. Look, you can throw all the tests in the garbage, and this is the most important one. Without it, you cannot diagnose. See, visible pus was found in all joints and cultures of the joint, and the abscess grows Streptococcus pyogenes. Even if you don't have this one, let's see the other test. The CBC is high, so it looks like an infection. The ASR is high, and you will only see this in two things: either a rheumatoid factor, uh, like for example in juvenile arthritis or septic arthritis. ESR means there's an inflammation, but CRP confirmed that this inflammation is infection, not because of like inflammatory process. Okay, the haptoglobin is normal, so it canceled the sickle cell. Rheumatoid factor is also normal, so it canceled the juvenile. The Lyme is negative, it's already canceled the Lyme. We still have reactive arthritis, which is already canceled because we have the synovial fluid to grow for Streptococcus pyogenes. So okay, you have it in front of you. Then what should you do?
Antibiotics, right away.
Which is
Doxycycline. Or Vacaville.
doxycycline.
Doxycycline.
Why doxycycline?
Doxycycline targets gram-positive bacteria, and the
You know, doxycycline, I will only use it in one case. Only one case.
chlamydia.
Chlamydia. Otherwise, I won't think about it at all.
Yeah,
TMX.
penicillin.
Penicillin.
Was shot by genius.
TMX, I will only use it in like UTI stuffs.
Could you go for ceftriaxone?
Sacrifice by genius.
What?
Ceftriaxone.
Ceftriaxone. Yeah, could be. Look, if we are right now like we are waiting the synovial analysis, okay, we took it and we're still waiting the answer of it. I will start two medication, ceftriaxone plus vancomycin. Why? Ceftriaxone will cover all the gram negatives, and vancomycin will cover the gram positive with, which is the most important bacteria, MRSA,
Yes.
which is more resistant bacteria.
Yes.
Okay, if you start amoxicillin as an empiric antibiotic, you will cover those like bugs, for example, let's say biogenes, but you won't cover MRSA.
Isn't Versa also a thing?
Versa, if you have a vancomycin resistant.
Yeah.
In this case, you will start something more stronger, like a carbapenems.
Carbapenems.
Yeah, or like there's also another drug which is the
Piperacillin. Linezolid. Linezolid.
yes, linezolid. I think they took it from the market. You will not find it right now, except if like for some situations. But always start Cef plus.
So when they
Thank
say broad spectrum antibiotics, this is what they mean?
Yep. Broad means like cover everything.
Yeah, cover everything. But are they the two antibiotics?
No, there's others. For example, as like Salim mentioned, piperacillin, tazobactam. That's a broad spectrum, which will cover like a whole of gram positives and gram negatives. But if you are, if you specifically want like to attack a MRSA, I prefer Vanco than piperacillin. Piperacillin can cover it, but vancomycin is better. Okay. So the diagnosis was septic arthritis. At the time, like sometimes they call it infective arthritis, I think. So the treatment was like this: they made incision and drainage. Okay, this is always the answer. Sometimes they put antibiotic or like incision and drainage. First, you do the incision and drainage, and then you start the antibiotic. Okay, because it's super important. You want to take the pus inside of the inside of the joint. You want because it will not get maltreated in this case. So the patient underwent an abscess incision and also the drainage from the joint space. The medical management, we start amoxicillin plus sulbactam. Why? First of all, we had a biogenes as the cause of this. So they start amoxicillin plus sulbactam, which is an IV drug. Okay. Usually you will not see it a lot in the exams. They won't like start directly with it, but it's like a cheap drug and it will cover for the biogenes. So that's why they started. Okay. But always keep in your mind, you start with the empiric and then you wait the culture. The culture will give you the antibiotic, which is like effective for this case, and then you will change.
Sulbactam is a beta lactamase
Yes,
inhibitor.
yes. There's a there's actually my two drugs, amoxicillin plus clavulanic acid.
Clavulanic. Yeah.
This is oral, and this one is IV. Sulbactam is IV.
I have a question, please.
Mm-hmm.
Let's say that we got the culture and the bacteria is sensitive for the ceftriaxone, for example, which is wide spectrum, and also it is sensitive for narrow spectrum. Should we switch from the wide to narrow, or just keep it with the wide spectrum?
So does it like only like let's say the culture? You mean like it's sensitive for ceftriaxone plus another drug which is a narrow spectrum, right?
Yes, for example, amoxicillin, or I think for oxacillin or cloxacillin, for example.
Yes, clinically there's like two scenarios. If it's like in the first week, let's say that you have the course would start in like 2 weeks or 3 weeks, sometimes, or like 12 days, or like let's say 14 days. If you are still in the first days, you will change. But if you already finish it, let's say that you You passed like a 10 days with a ceftriaxone, keep it because you're already gonna finish it. You don't need to go to another antibiotic and then start again 2 weeks or 3 weeks.
Thank you.
Okay. And the outcome, the patient was cured and discharged, and follow up after 2 months showed there's no for example, infection again. The squilla was normal. There's no any like nephritis or rheumatic fever. That's super important. Biogenes in children always need to be treated because it can lead to rheumatic fever or acute streptococcal glomerulonephritis, and those two conditions are not treated. You cannot treat those conditions. So we ever see biogenes in it, and like children, at least start amoxicillin, at least treat it. Okay. So I'll wrap up. I'll talk about septic arthritis. I think it's an easy topic, but it's super important. You will see it a lot in your clinic. So, also known as an infection of arthritis, it's a serious and a painful infection in joint, food, and tissue. Typically, you will see erythema of the joint as this patient presented. They will have a limitation in the movement of the joint. It will be also inflamed, redness, etc. It looks like cellulitis, but it's more affecting the joint. The etiology, the most important, is the bacterial. And this is actually depends on the age. Children, it will cause by gram-positive, which is either staph aureus or staph or like strep biogenes. If it's in the college age, like let's say from 18 to 20 years old, it would be caused by what? By like Neisseria, because at this age are so much common between those age group. And in this case, you need to start directly with a ceftriaxone. Okay, if it's in the older, which is from 18 to 65, it's most of the time it's a staph aureus. Okay, and they ask this always in the exam. They like to bring a question like, what's the most common cause of like septic arthritis? And you say staph aureus.
How do we know the duration? Why it's 24 days? For example, we used to treat pharyngitis with amoxicillin for 10 days, maximum of 2 weeks.
Okay, you are totally correct. We do the regimen for like 7 days or 14 days, but the longest period it could be also sometime like 1 month or 2 months. Like it depends in the clinic. So like if the doctor, for example, they start sulfobactam like normoxicillin, and they keep the patient in the inpatient ward. If they already planned to give the medication for 1 month, then they should give it like this. The guideline like change sometimes. You can find them they give the medication for 7 days or 10 days, but it should be between 10 to like 1. Also, we talked about Lyme. Lyme, you will see erythema migrans. It's with wrong eczema. It should be erythema migrans. If it's like in the third stage of Lyme disease, let's say that you missed Lyme, and the patient came after 1 month or 2 months of like infected Lyme, they will start to develop those symptoms, which is AV block and neurological manifestation. In this case, you will not treat with doxycycline. You will treat with the IV ceftriaxone. Okay, doxycycline, it's only in the first stage of Lyme. The last stage or the late stage, if there's an AV block, or if there's arthritis, or there is like a neuro manifestation, you will start IV ceftriaxone. And this is always, they bring this question always, they want to confuse you. And if the patient is pregnant, never give doxycycline to a pregnant woman. Never ever. Pregnant, you either treat with ceftriaxone or sometimes amoxicillin. Ceftriaxone is better because it's an IV and works faster. Viruses, parvovirus, super important. Always we miss this virus. This virus looks like influenza. So you have like a joint pain and sometimes rash. Yes, the fifth disease. Yeah, the stab cheek. We see it in children. Plus the joint pain. Sometimes also it can cause like pleuritis or like a pericarditis. So don't miss this virus. HIV, of course. If the patient have a risk of HIV, always like check the CD4 count, and know if the CD4 count is already for like more than 500 or not. Otherwise, you will start the prophylaxis, etc. And fungal, not common. You won't see fungal, I don't think so. With the clinical presentation, as we saw in this case, there's like my loss of the active and the passive range. Yeah, you will see signs of inflammation, fever, erythema, etc. And if it's a gonococcal infection, you will see a pus, like a pustular skin lesion, because gonococcal have three things: have like a pustular lesion in the skin. Plus, you will see a discharge from the vagina or like the urethra of the penis, and you will see also an inflammation of the lips. And we have also like science depends on the like the infection. If it's Lyme, you will see the AV block and neurological issues. And the diagnosis, as I said, the most important one is the erythrocentesis. Okay, don't miss this. Always order the erythrocentesis, and you're gonna order each one alone, as I said. And you see the WBC count. Actually, there is a good figure I will show it after this slide to differentiate between gout and septic arthritis. Always order the peripheral blood leukocyte to see if how much like WBC you have, and CRP and ESR to differentiate if it's like rheumatic fever or if it's like an infection. You will do an X-ray and CT. Usually in the clinic, they do it as like follow-up to see if there's any like obstruction or like a loss of the joint space, just like to follow up. But it's not like a diagnostic. In the exams, they may drop an X-ray, want to like to see if you can like differentiate between arthritis or like infective, but usually like they don't ask this so much. So this is how to differentiate between rheumatoid arthritis and septic arthritis and like degenerative joint disease. They will like, for example, like in exams, like step two or step three, they bring this as like a labs. So they said they done the erythrocentesis,
And they ask for diagnosis based
yes,
on labs.
yeah, they will say like the erythrocentesis showed the WBC more than 50,000. So this is a septic arthritis. But if it's between 2,000 and let's say 10,000, then this is point more to like inflammatory disease. So it could be rheumatoid factor, it could be rheumatoid arthritis, could be juvenile if it's a child. Okay, so whenever you open a synovial fluid analysis, three things. The first thing is the glucose. If the glucose is low, that means this is an infection. Then look at cell count. If it's a high WBC, then this is an infection. Plus, look at the crystals, which is I don't think it's here, but the crystals will give you a hint. So if you see like a negative perfringated crystal, that means this is yes, means this is gout. But if you don't see anything, that means this is a septic arthritis. Okay, I recommend memorize this. This is super important. Always keep this in your mind. Now seeing an X-rays. So for example, look at here. The X-ray, like as you see, it looks like normal. There's no like any specific pattern. Here we can see a little bit like of distraction. I don't know if you can see it or not. Let me just put the laser here. There's a little bit like a distraction in the joint, and this is like specifically after 3 weeks of the infection. So you start to see a narrowing of the joint and kind of like of distraction of the bone. Okay, here is the same. Here is normal, and here's the difference. You can see there is like distraction plus kind of like a bubbling outside. Looks like an inflammation. Okay, X-ray won't show you a lot, but the MRI will give you a lot of hints. So this is normal, and this is the infected one. You can see how much is light means there's a lot of pus inside, and kind of like distracted. There's like a bony distraction right there and here also. So you can like differentiate between the normal and the abnormal one. Ultrasound will give you a hint if there's like effusion or not. So right here, like we see, this is all of it. This is a fluid. Anything black is a fluid. Okay. And here is the femoral neck, and here's the capsule between the pelvic and the femoral neck. There's also fluid. Here's my accumulated, so that's kind of give you a hint that there is the kind of like inflammation and fluid inside. As I said, it won't give you a diagnosis of septic arthritis, but it will give you a hint. And as we said, like the treatment, we start with the wide spectrum, and then we start to go with like narrower according to the culture. For Lyme disease, we started doxycycline, still the same thing for like 28 days. Doxycycline need to be continued for 1 month. You cannot do it like for 2 weeks. You need to continue on. That's why we don't like it. It's so much takes long. Plus, there's a lot like of side effects. Doxycycline is not good. Amoxicillin or like cefuroxime, which is another third generation sport. And the treatment, if it's like a joint gets so much affected and there's a lot of, like of destruction, you should call the surgery.
So basically, we stopped at the treatment of septic arthritis, and usually, as any kind of an infection, if there is a pus or or like an abscess, which is happened because of the infection or generated because of infection, you need always to uh, drain this abscess. Okay, and the case is also the same in septic arthritis. Then after this comes the antibiotic part, and it's important to know which type of antibiotic you should give and which one you should avoid. So in general, you start with a wide spectrum, as we discussed in this case. We start with a wide spectrum antibiotic, and then according to the culture and synovial fluid analysis, once we know the bacteria, we're gonna narrow our antibiotic. Okay. Most of the time, we start with two antibiotics, which is ceftriaxone plus vancomycin. You can go with piperacillin tazobactam, is also wide, or cefepime, like fourth generation cephalosporin, or carbapenems. The best one always are ceftriaxone plus vancomycin. Okay. If it's Lyme, then as we said in the case, it's either doxycycline. Doxycycline is okay, but it's not good in pregnancy. It's teratogenic. It will lead to fetal issues in the pregnancy, so take care of this. Don't give it. In its place, you should give amoxicillin or ceftriaxone. Okay, and if there is a full destruction of the joint, which is you will see it in the X-ray or the MRI of the hip or the knee. In those cases, you need to consult orthopedics, okay? Because here we need a surgical intervention, and sometimes prosthetic devices need to be done. So this is a table about the antibiotics which is used in each kind of bacteria, or which antibiotic is effective against it. Most of the time, you need to know this. That's important, okay? You don't need to miss any kind of bacteria, and you need to know each bacteria and which antibiotic is effective against it. Okay. First line, you should know it. Second line, it's optional actually. Depends. You should have an idea, but I recommend first line. You should always keep it in your mind because that's most of the questions in the exam. This figure is more easier. Shows that if it's in children cases, then mostly it's the staph aureus. If it's in neonate, mostly it's group B streptococcus, and if it's in college age around 18 or 20s, that's most of the time it's Neisseria gonorrhoeae. Of course, the symptoms also would guide you. If there are symptoms of meningitis, that means it's Neisseria gonorrhoeae. Okay, then in Neisseria gonorrhoeae, you need to treat with Cef, not penicillin. Okay, and that's the end of the session. Thank you all for watching. Don't forget to subscribe.